What I thought the panel might start by talking about is what kinds of things might leaders such as the ones in front of us and the ones in this room do to begin addressing the challenges of cost and quality in the U.S. in the absence of major change from Washington. And I actually thought we'd start by having everybody put their employer hat on, since one of the things you all share in common is that you are large employers. I'd like you to talk a little bit about, as employers, how much the rising cost of healthcare are a problem for you, what some of the things are that you're doing to address those issues. Similarly, what sort of issues you're trying to grapple with respect to the quality of healthcare. So those are sort of the two parts of the value equation that we talk about.
But there are features that we and other organizations have developed in our culture over the years that we think are important. You know, there are things like the patient-centeredness that was talked about before. For us, we believe strongly that physician or provider leadership in the organization, people who know about caring for patients, being in the leadership roles is important. The right kind of IT and technology investments in our environment, salaried physicians is an important element, although there are very successful systems that don't have that. A follow-up was discussed, the Gawande article. There was a follow-up article, I can't remember what paper it was in, but Gawande, Berwick, McClellan, and one other wrote, and it was about, they had identified 74 high-value areas of the country, and they brought 10 of them together to talk about what were some of the features of high-value healthcare systems. And I think one of the striking things about that was there was a lot of diversity there. There were some common elements. I think the patient-centeredness was one of those. But there are a lot of ways that people have organized or managed to figure out how to maybe even not be part of the same organization and deliver care in a very effective way.
We spend $2.2 trillion here in the United States. PricewaterhouseCoopers would tell you $1 trillion of that is waste. Half of that behavioral, right, smoking, diet. If it's a $500 billion bucket of waste we could go after, and largely by using lean disciplines and other leadership tools that NCHL and others are proposing, and we obviously support and actually would love to accelerate. That's a massive opportunity for healthcare reform, and I'd love to see us collectively partner to get at that waste, whether that's in patient flow or asset optimization, even in the short term. If that means I got a dip in my business, I'm all for that for the long term. You know, regulation around staffing ratios, I mean, that's a little more challenging, but how could we bring innovation and technology to get that waste out, to better deploy it for whether that's access or whatever we want to do with those dollars. But the numbers are absolutely staggering. And I'd love to see our collective agenda spend much more time and energy and leadership development, since that's what we're here talking about, in those skill sets.
The question in particular about the relationship between cost and quality and spend and quality is a very complex one. And as I think you know, Beth, there was a recent publication. We led a project with the other UC hospitals, with the UC hospitals in California, looking at this question in a specific population. And that data indicates that additional resources resulted in lower mortality. Now, that then sets up the question, how much resources for how much immortality? And that's a legitimate question, but that's a very different question than suggesting that kind of in all cases, more spending, lesser quality. And then finally, the quality question all depends on what you're looking at. And this is all available. The nice thing is it's all available on hhs.gov or whatever the Medicare website is. One can take a look at the quality results on that data and look at the institutions and how they're typically looked at as either high resource use or low resource use. And you see some very interesting pictures.
For us, it's all about the money. Still. It's all about the money. And what that really means is the long-term financial sustainability of organizations represented here, as well as the smaller ones. What we have seen in the past 12 months with this crisis is that the organizations that are smaller, organizations that are perhaps less financially strong, have been effectively shut out of the capital markets. They have no access to capital whatsoever. And that is changing behavior, that is changing strategies, that in and of itself we think will become even a greater change agent of what is actually taking place, not only in the operations of health systems, but also in the structure of organizations as well as the relationships of organizations like Mayo or Cedars-Sinai and some of the other large ones as they relate to smaller, perhaps more financially weak organizations. Every year, we, along with the AHA and HFMA, sponsor a investor conference for the nonprofit world. And we have 35 to 40 health systems make a presentation to some 400 or 500 capital markets participants on Wall Street. In May of 2008, every one of the health systems said that their number one or number two priority was growth. Everyone was going to grow. In May of 2009, out of the 35 presenters, 2 said growth was an imperative. Every one of the others said it's all about operational efficiency, it's all about reducing cost, and so the crisis has actually accelerated the focus in on what we call the operational transformation towards greater financial, predictable sustainability. Because without that, there will be no access to capital, and that in and of itself will be, we believe, a motivating factor. More specifically, though, for the last 7 years, we've been gathering data of some 200 health systems across the country representing roughly 2,000 hospitals. And some of you have seen this data before on the fairly persuasive case that those larger organizations have a better financial track record than the smaller organizations. But what's more important is that starting last year, we started to track the financial performance of those organizations who perhaps are more highly integrated, where there's a better coordination of care compared to those that are not. And we've looked at the outside surveys conducted by Verispan, not attesting whether or not that's the appropriate means to measure or determine the effectiveness or the degree of integration. But what is absolutely astounding, and it has been the case for the last 5 years, is that the financial performance of the most highly rated integrated systems far outpaces the financial performance of those that are less integrated by a measure, a meaningful measure. And that, in a crisis of focusing in on financial sustainability, we think will be an additional motivating factor to, in fact, encourage organizations to look at the Kaiser model, the Mayo model, and things of that sort, to better coordinate, because there is a financial reward. The data show that is indeed financially, you're going to be in a stronger financial position if you do that, and that will lead to sustainability, that will lead to the continuation of having capital access.